Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Kevin. How are you doing this morning?
Good, Dennis. Thanks for having me on again. I appreciate it.
Hey, I appreciate you coming on and giving us some of that experience you got. So today I would like to talk about using narcotics like a long term, right? So, kind of classic PFC situation, Africa, you're waiting, you're holding on to somebody 96 hours. And especially if you're looking at the PFC, the Analgesia and Sedation CPG, the recipe they have for your ketamine is like a pretty hefty one. So I know that these drugs get broken down in the body. They create metabolites. And I'm just wondering, how do is that stuff important? Does it factor into how I use my narcotics? Should I be adjusting things? Like how does this come into play?
So, yeah, I mean, it's the metabolites are important, but there's also another thing I'd like to talk about, and especially when you're using infusions, and it's something called the context-sensitive halftime. And that's when you have an infusion going for however long, whether it's 6 hours, 24 hours, 48 hours. It's defined as the amount of time that it takes for the drug concentration in the blood to be decreased by 50%. So, for example, let's just talk about fentanyl. So, fentanyl it's a synthetic opioid. I obviously looked a lot of this stuff up. I was kind of reaching back to my notes from pharmacology, but fentanyl, the metabolites in fentanyl aren't something that you need to worry about. But fentanyl, of all the narcotics, does have the longest context-sensitive half-time. So, when you look at whether it's morphine or Dilaudid or fentanyl infusions, the body, the volume of distribution is significant. So when we talk about the context-sensitive half-time, we put fentanyl in the bloodstream, and then that creates a concentration gradient, and then that it diffuses down the concentration gradient. So you want it to go to the brain and the spinal cord. Those are the two places where it works. But it also, when you're using an infusion, it goes into your muscle tissues, your other organs, and your fat cells, and it absorbs a lot of that. So essentially, you create, when you have a fentanyl infusion for a couple hours, you're creating kind of a fentanyl sponge, so to speak. So you can use this to your advantage. So let's say during an anesthetic, you run a fentanyl infusion and low dose, maybe 25 mics to 50 mics an hour, and that's probably something that you would push otherwise. So if you run that for 4 or 5 hours, which I've done before, what that creates is a good pain plan for after the case, where the fentanyl redistributes into the bloodstream, the concentration gradient goes up, and then it goes back into your brain and spinal cord. So you get this kind of prolonged effect of fentanyl without having to give fentanyl. So now everything we do, we talk about this, has a risk and a benefit. So what's the benefit? The benefit is you get this prolonged analgesia after your case. The risk is that at the end of the case, if you've overshot on your fentanyl and they don't ventilate, right? So now you've got all this narcotic on board, you're way above the apneic threshold, and they're not ventilating. So you have to, I think most adults, 25 mics an hour, 50 mics an hour, you're going to stay below the apneic threshold. They'll ventilate after the case. And then they've just got prolonged analgesia. And one of the places where I trained, they did this all the time, where they did this with spine cases. They did this with cranie cases. And it worked well, where you essentially turned your patient into this fentanyl sponge. And then afterwards, it just redistributed back into the bloodstream. Once it's in the bloodstream, it goes to the brain, back into the spinal cord, and you get this prolonged effect. But this isn't a U.S. hospital-based system where they go to a recovery room or they're going to a place where they are monitored. So um, you just have to take that into effect where, if a patient all of a sudden you've overshot or you no longer given surgical stimulus and now the pain stimulus isn't as great, they might go apneic. So you got to keep an eye on them if you do this. So, and then the other one that we think about with, especially downrange, if you have somebody on a midazolam infusion, right? So when you think about the three different kind of anesthetics that you would use downrange, or so ketamine, which is a dissociative anesthetic, midazolam, which is a benzodiazepine, which you're using it to create amnesia. And then there's propofol. Propofol is the same, like you're just using it to create amnesia. So, downrange, probably not going to see a ton of propofol far forward. Maybe when you get to a roll 2, roll 3. But I never carried propofol. It was just too big of a volume. And then for trauma patients, like I just avoid it completely. But so midazolam, the context-sensitive halftime between midazolam, ketamine, and propofol, midazolam has the greatest. It's not horrible. I think it's about, like, if you're running an infusion, it takes about an hour to get half of the um, concentration in your bloodstream. So if you turn it off, you're waiting about an hour for half of that concentration to drop, where ketamine and propofol, it's about a half hour. So, but really the important part is the clinical effects. So like when one of the clinical effects going to wear off, and that's typically what you're concerned about. But I've run midazolam ketamine infusion for 8 or 9 hours on a case, and within an hour, I've got the patient extubated, oral airway, doing fine. So, and that's given quite a bit of midazolam. So, as far as when you're looking at the metabolites of some of these medications that we use, so morphine has a metabolite, and I'm just going to read this so I don't mess it up, and it's morphine 6 gluconoride. And that is two times as potent as morphine, right? So, and that has a much longer half-life than morphine. So if you have somebody that's getting a lot of morphine over time, you might run into issues with that metabolite where you're, they just become apneic, or you've just overshot on your morphine, because that morphine used to metabolize, it metabolizes into that metabolite, which is actually more potent than morphine itself. And what I've found with morphine is the initial dose is too low, and then you start dose stacking. So like if we just use the example of a patient-controlled analgesia, I think they've gotten away from using morphine and they used Dilaudid. And the reason being is morphine has pretty a large amount of variation of the crossing the blood-brain barrier in patients, where Dilaudid is pretty, like everybody, you give Dilaudid within 60 seconds, you see the effects. Morphine, it's variable. So you're given morphine, you don't see the effects, and then all of a sudden, bam, all of it just is crosses the blood-brain barrier, and now you see all the effects of all the morphine you just give, and you can get yourself into trouble. So that's a pretty significant metabolite. The other one that I don't think I've seen it clinically as much as you would, like when you read about it, where you're like, oh my God, I'm never giving morphine again. Like I've just not seen it clinically. But the one that I have seen clinically is ketamine, or excuse me, not ketamine, vecuronium. Vecuronium has a metabolite, and it's norcuronium. And I read a couple of different places. Some places say it's about 50% as potent as ketamine or as vecuronium. Some books will say about 80% as potent. But where you run into trouble with that is people that have kidney disease. So they have a decreased GFR, that metabolite doesn't get cleared as fast. And I have actually seen that once clinically, where I was using, it was a long case, 8 or 9 hours, and I was using vecuronium. And this is back in the day before sugammadex. And I had to use neostigmine glycopyrrolate to reverse the patient. And they gave him a full dose of reversal, and the patient still was weak. Waited about 45 minutes. Once it redosed the reversal, which is controversial in itself, but the patient still remained weak, and we left him intubated, brought him to the ICU, and then just a tincture of time. So it was about 5 or 6 hours, and then went back, checked his neuromuscular blockade, and it was gone, and he was awake and ventilating, and we did all the tests, and then we extubated him. So that one you can run into trouble. So where would that come into effect downrange? Like if you had somebody with an acute kidney injury, which trauma patients have, right? They become hypotensive, they get an acute kidney injury, and now you're sitting on them for 96 hours, and maybe you are using vecuronium during surgery, and now you want to get them extubated and awake, or ventilating on their own, and it just takes a long time to wear off. So I don't know. I would assume, and this is just an assumption, that now that we have sugammadex, which that stuff is like magic, it'll probably make that go away, assuming that's what you have, like if you have sugammadex. But if you don't, then you just have to, it just takes time. Now, ketamine does have a metabolite, and I've only seen this once. It was actually recently where, we typically can give 50 of ketamine before incision. So the patient's asleep, they're intubated, we've got, potent inhalational gas going. And right before incision, we'll give 50 of ketamine. And that way it just kind of blocks the initial pain stimulus to the brain. But like that should be gone in 15 or 20 minutes. Like I've given 50 of ketamine for short case, 10 minutes, and they wake up, they're fine. But this particular patient, I think we were about 2 hours post-op, and he still had nystagmus, right? So and he was still acting like he had a significant amount of ketamine, and it was only 50 milligrams. So then we started questioning, was it really 50 milligrams, or was it 500? Was the concentration correct? But looking back, it might be that this gentleman just had this prolonged effect from the metabolite of ketamine. Now, was there any danger to it? No, he just was acting like he had ketamine, and he just was sitting in PACU for like 3 hours. Just looked like he was. I was like, wow. Like I've never seen it before, and I've given a lot of ketamine, and that was the first time. I'm like thinking back, like maybe that's what it was, just that metabolite. And he was a slow metabolizer. I don't know. So that would be the concern with ketamine. But even then, is it is it a concern? Probably not, because it's not going to make you not ventilate. It's just going to have this prolonged effect. And I'm trying to think some of the other meds down. So like Dilaudid, once again, synthetic opioid. Didn't really see any thing that I read about metabolites. But the one drug that we learn about in nurse anesthesia school is Demerol or meperidine. And I have seen it downrange. I've seen it used, especially early on in the war. We're talking 2004 or 5 in the ER, where we were giving Demerol for like whatever. So the normeperidine, which is the metabolite of Demerol, can lower the seizure threshold. But I don't think a dose or two of Demerol is going to, unless, obviously if you have a head injury or you're prone to seizures. But what I've read is it's got to be chronically used over time, and they build up they just build up a tolerance to it. Now you got to give more and more, and then you have this increased metabolite in the bloodstream, and now you're starting to lower the seizure threshold. But even then, looking back, back in the late 1900s when I was a new nurse. um, it was commonly given to the floor I worked on was for pancreatitis. We would give IM Demerol. And I distinctly remember this one patient where he would come in frequently in pancreatitis, and I would inject him with 400 milligrams of Demerol Q4 hours. And I don't recall him having a seizure. But it exists. It's there, and those are the ones, and those are the big ones, especially the ones that you see downrange. So I can't think of any other meds downrange that you would see that have these like significant metabolites that you'd have to worry about. But now a lot of these metabolites are cleared renally. So most of these medications are, either metabolized in the liver and they become water soluble and then they're excreted in the kidneys. So that water soluble metabolite is what you need to worry about. Because if you're not clearing it via the kidneys, then it builds up in the system, and that's where those metabolites come into play.
You mentioned earlier you're talking about context sensitive, like half-lives. How I guess everybody being different, and that can be the amount of body fat they have, the amount of proteins that are floating around in their blood. Like, I guess how do you factor that in order to get your timing right? Like, how do you figure out how big the sponge is in order to get the effect that you wanted?
Yeah. So when you're doing a total intravenous anesthetic, like those are challenging when you're going to wake somebody up, right? And I know we talked about this before, and I always tell the people that come into the OR that are learning anesthesia, it's fairly easy to put somebody to sleep. It's very challenging to wake somebody up on a like right when this, like you're done suturing, and all of a sudden the surgeon's like, "I'm done," and like you pull the ET tube, and the patient's like, "Hey, I'm ready to go to the PACU." Like that is very challenging when you're doing a TIVA. It's becomes even more challenging the longer that TIVA goes on. So, and that just comes with practice and understanding when you should decrease your infusion rates or shut them off, and knowing the context sensitive halftime is like, okay, yeah. So the when you're using midazolam and you're trying to wake somebody up, that's where it becomes challenging, just because of the context sensitive halftime is longer than propofol. So your timing can be off. And I always, obviously, I side on the uh, cautious side, where I would prefer them to wake up after the surgery is done than when they're closing. Um, so those are some things to think about, is just when to shut this stuff off. And usually a good swag is about half hour before you're done, is to start turning that stuff off. And then you can bridge with, because typically if you're getting closer to the skin, I always find that that's a lot more sensitive when they're suturing than some of the inner layers. If you got them back ventilating on their own, just working some narcotics, some fentanyl to a respiratory rate of 12 to 14, typically you'll get them through that last 10 or 15 minutes of sewing. Now that you've turned your midazolam ketamine infusion off. So that's where the context sensitive halftime comes in. And then also too, like the wake up test. Like if you're trying to wake somebody up, like when you turn off that midazolam ketamine, like it's just going to take longer than if you were using propofol.
So you wait about a half hour, you turn off the infusion. The surgeons are finishing up suturing, or they're completely done?
So like I mean, obviously this is a conversation between the surgeon, and I always kind of preface this with like, guys, I don't care when you get done. I'm just trying to time my wake up, because if you keep asking them, "Are you done yet? Are you done yet? When are you going to be done?" Obviously that causes a little friction. So I usually like, "Hey man, just for purposes of me having a timely wake up, what do you think you got left?" And then they'll tell me, whatever, half hour, 45 minutes. And then I kind of base my titration off of those medications, the answer that I get from the surgeon. And don't get me wrong, it's challenging. Like waking up somebody from a TIVA is challenging. The most challenging part is just getting, like, if you get them back ventilating on their own, then that's almost 90% of the battle. Like, just okay, they're ventilating on their own, and like once you do that, then really, turning off your infusions, you can wait a little bit longer, versus if somebody like is not ventilating on their own, then you got to turn those infusions off, get their apneic, apneic threshold, hit the apneic threshold, get them back ventilating, and then go, okay, now I kind of know where I'm at.
All right. So, and then as they're, I don't know, as they're recovering, obviously they're going to start moving around because that what has just happened, like that still hurts, right? So then you're just going to your pushes, or do you start using like your longer acting opioids, or I
Um,
guess how do you
well,
normally play that?
I guess it depends upon where they're going, who's going to be watching them, and kind of, are they going to stay intubated? Are they going to get extubated? If typically in a prolonged patient hold environment, prolonged field care environment, I just turn my so I use the ketamine Versed mixture, the old school one from the war surgery manual, and I just decrease the infusion rate. And even if I have them extubated, I've done that before, where I half it or bring it down to three quarters of what it was, get them back ventilating on their own. Everything looks good. I extubate them, and then I use that as my sedation analgesic over the course of however long I'm going to hold on to them. And I know they've removed the Midazolam out of the ketamine infusion. Um, and I think, in speaking to some of the people that have written that CPG, or the battalion docs that have to give their medics their right and left limits, I get it. Like, if you have, a bag of ketamine or a bag of Versed or a bag of whatever, there's always the risk that you leave the roller clamp open and the whole thing gets infused. I get it. Like, but I think there's a risk to not doing that, right? So, like, if you have somebody that's got an infusion of ketamine going, and now they become either combative or disassociated to the point where you can no longer like talk to them and be like, hey, I need you to lie still, or hey, everything is fine, like you just had surgery. And now you have to give bumps of Versed. I always find in that scenario, you typically give more than what you would have if you would have just had an infusion going, because now they're at a point where they're kind of combative, and you're trying to get control of them. And you're trying to get control of them with a chemical agent. And typically, to get control of them, you have to give more than if you'd have just had a basal rate of the infusion going. So I think there's a risk to putting Versed and ketamine in a bag. Yep, you can leave the roller clamp open and the whole thing gets infused. But there's also a risk to not putting it in the bag, and that risk is a combative patient that requires more midazolam in the first place than it would have if you just put it in the bag. So choose your poison.
When it comes to like metabolites or context sensitive like timing, um, I guess what would you want people to walk away with? What would be the most important thing?
Um, I would say probably the most important thing is if you do have somebody that has low urine output, if they have an acute kidney injury, just be aware that they might require less medication, just simply because those metabolites are building up in the system and they're not being cleared appropriately. And then the context sensitive halftime, like, if, say, for example, you're in a prolonged hold scenario, prolonged field care, and there's a hard time. There's like, hey, at 002, there is a vehicle that's going to show up. Has a non-medical attendant, but that's who's evacuating your patient. And you have somebody that's on like this infusion, like, you're going to have to time that appropriately, because what you don't want to do is kind of goof that up and have them still like severely sedated, or maybe they're requiring some sort of airway adjunct, whether it's a nasal trumpet or just because they're still fairly sedated. And now you have to hand this off to the vehicle of opportunity that's going to get this, guy or girl back to wherever. Just know that when you have somebody on an infusion and that infusion's been on for a while, like it's going to take a certain amount of time for that infusion to the concentration in the bloodstream to decrease by half. And you can Google this, there's context sensitive halftime of medications, and you can find the graphs and just go, okay, if I know at 2 o'clock, this vehicle of opportunity is going to pick up this patient non-medically attended, then I need to definitely have this off by this time. And that way that patient is going to be awake and talking to you when you hand that patient off. So those are the kind of the two big things I would say take away from context sensitive halftime and just the metabolites that are you get from these medicines.
Awesome. I really appreciate you jumping on and walking us through this.
Yeah, of course, Dennis, anytime. It's always fun to come and chit chat, talk about drugs, my favorite topic.
Yep, mine too. Awesome. Well, thank you.
Yep. You have a good rest of your week.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.